So one of the promises of these new drugs is that they're good for the high-risk patients, and I'm really focusing on the 17P because that's the most well-defined group. And the data is impressive, but not as impressive. Can you hold our hand through that and tell us what you see there? Because it looked to me like the Kaplan-Meier curves weren't nearly those wonderful flat lines that you see.
Yeah, I think that tells us, definitely the 17P patients within the first 2 years have a drop-off, and some of that is patients develop Richter's, which ibrutinib probably doesn't work against, and that's probably Richter's often it's there before. And then patients relapse with CLL and they have mutations where they've outsmarted, the drug. And that tells us again that the drug and what it targets, the BTK, is real important. But it also tells us that those tumor types are smarter, in the sense that that they're more prone to developing mechanisms of resistance, and that's probably the group. That's the group of patients that, as we move forward, we're going to want to be looking at combination treatments. Either monoclonal antibodies with ibrutinib, or other agents that work independent of p53, dinaciclib, phytopyridol, maybe another BCR signaling agent. And that's what Dr. Johnson in her talk at this meeting alluded to was, well, is the pathway still activated? And the pathway is still activated that when patients become resistant. So it also opens the opportunity that, just getting back to what we were talking about with CML, the T315 mutation in CML makes imatinib and most of the tyrosine kinase inhibitors not work. But development of a new tyrosine kinase inhibitor that works against that, it reverts that disease, even that bad subset of CML, back to something that can be treated. And there are in fact BTK inhibitors that are in preclinical development that are about to start clinical trials, that should work against the mutation that's being seen in CLL right now. So I think in some, the 17P patients who have had a lot of therapy that go on ibrutinib, we probably will be giving ibrutinib with something else, and whereas the other group, if our goal is suppressive therapy, you probably will be able to just get by with ibrutinib by itself, unless your goal is to target minimal residual disease.
So what you're talking about here is something else. You're talking about monoclonal antibodies, but you're also talking about, I think you have a trial with the lenalidomide too that's opening up. But are you talking also about bendamustine or fludarabine or?
No, I don't think there's really, for 17P patients, it's really not appropriate in my opinion for them to go on trials with chemotherapy, because chemotherapy, molecularly we know it's much less effective, and those tumor types are more predisposed to DNA damage. And Tom Kipps mentioned this, that nobody can prove it, but everybody thinks that chemotherapy might even drive these tumor types, and so I think that was a common theme that came out of the discussion on 17P CLL is we really shouldn't be using chemoimmunotherapy in these patients. We should be using agents that we know work against 17P disease and may not make things worse.
And I have to say that that's something that patients have felt for a long time, and I think some of the thought leaders in CLL have felt all the time, but has not been an understanding in the community of treating hematologist oncologists, where they say, well, there is some response in 17P, we'll give it a try. Maybe you'll be part of that lucky percent that does respond.
Yeah, and I think that's sort of, you say something very important, that if you're a patient with 17P CLL, you have a very uncommon type of CLL, and you should be being seen at a CLL center of excellence, where they have clinical trials that are specific for 17P, and there's really the recognition, because 17P CLL is not a garden variety disease that that a general hematologist or oncologist probably should be treating without help from an expert.
All right, let's pause there for a minute and we'll pick up.